Hi, and welcome to our highlights video from ASCO 2019. I'm here with Assistant Professor Bishal Gyawali. Thank you for being here.
Thank you very much for having me.
So what's your overall impression of this year's meeting?
I'm actually pretty impressed with this year's ASCO. There are a lot of positives to take away from this ASCO. The thing that impressed me the most was the selection of plenary abstracts, especially the selection of the abstract which showed that the use of Medicaid expansion helped to diminish the racial disparities between white and black cancer patients with regards to receipt of the time to receipt of treatment. And this is not the typical abstract that you are used to seeing in ASCO plenaries. ASCO plenaries has always been about phase 3 trials, positive phase 3 trials, changing practice. So this is not the typical abstract that you see in ASCO plenaries. This is a health service research using real-world database. And this is actually a policy paper. This is a policy research. This is not a drug or an intervention research.
Yeah.
This research is looking at how the use of a policy initiative can help improve cancer outcomes for patients and help erase racial gap. So this is very exciting. This means your research does not have to be a phase 3 trial for you to get an ASCO plenary.
Yeah.
So this is a very big deal in oncology, getting ASCO plenary. So until now, policy researchers doing other kinds of research like meta-research, health service research, economics research, they always had some sort of the feeling of being a little rejected from ASCO because no matter how good quality research they produce, they are never going to get the ASCO plenary. But now they are confident that if the research is good, then you can get to that stage. So I think this is a very bold statement from ASCO. Of course, I'll talk about the implications of that particular research, but overall, I'm impressed with the selection of this abstract as the plenary A and B. The selection of the olaratumab trial as the plenary also impressed me a lot because this is a negative phase 3 trial.
Yeah.
And typically, negative phase 3 trials are either not published at all or they get published in very low-tier journals and definitely not at ASCO plenary. So the selection of olaratumab as the ASCO plenary also gives a very strong and important message to the oncology community that negative trials are as important to inform practice and treatment decisions as the positive trials are. So, and there are other couple of things that I noticed at ASCO that impressed me. So first I want to talk about all the positive things.
Yeah.
For example, they gave an important venue for discussion of cancer drug approval bars and the value of cancer drugs, financial toxicity of cancer drugs. So these are issues that usually they are ignored at such main conferences.
Yeah.
So now giving an important place for this type of issues at ASCO is a very important step from ASCO. And it also signifies that the oncology community now cannot just, turn a blind eye to these issues. We have always been doing that, like an ostrich, but we no longer can become an ostrich. These are real problems in front of us. We may have better treatments. We may have a new phase 3 trial showing improved survival, but there is no point in having new drugs that the patients cannot have, the patients cannot have access to or afford. So in one of my papers, I have written that the discovery of these new molecules for most of the patients in the world, it's like the discovery of a black hole. Someone says there is a black hole. It's exciting from scientific point of view, but from the practical utility point of view, if 80-85% of the patients can't use that drug, then what's the point in having that drug?
Yeah, definitely.
So these are the positives that I drew from this ASCO conference, and I'm very happy about it.
Has it been different to other ASCO conferences, bringing up issues like that?
It has been different from many other conferences because, as I mentioned, the usual conferences, they always give top priority to phase 3 trials. New drugs are hyped, irrespective of their margin of benefit, no matter whether they improve surrogate or real endpoints. and no matter what the cost is. So nobody wants to talk about these issues. Everybody wants to say, wow, we got a new drug in this cancer. We never had a drug for this cancer, so this is a big deal, even though that drug is improving a surrogate measure by only 2 months, 3 months.
Yeah.
Everybody wants to jump on the bandwagon and everybody wants to celebrate something because everybody is here for celebration. But on the flip side of the coin, we have to be aware of the fact that these drugs may not be helpful for all the patients. Even for those patients in whom they help, that help may only be in a surrogate measure that may not translate to real clinical benefit in terms of improved survival or improved quality of life. And patients may have to pay a huge amount of money for that gain. And the trade-off may not be as optimistic as we are painting it to be. So I'm glad that at least at this ASCO I found that the other side of the coin is also being discussed equally, if not more importantly than the usual meetings.
Yeah, and just moving on to endpoints and assessing overall survival, how important is that to these trials?
It is very important, and I think we have a couple of very good examples from this ASCO meeting. First, I want to use the example of olaratumab, and I also want to highlight the issue of accelerated approval in this regard. Olaratumab is a drug for soft tissue sarcoma. It was tested in a phase 1, phase 2 trial, and the primary endpoint was progression-free survival. The drug did not improve progression-free survival, but surprisingly, it improved overall survival. And the difference in overall survival was huge. It was like a year. We have never seen that in sarcoma, an overall survival benefit of more than a year. But that was not the primary endpoint. The primary endpoint was progression-free survival, and it was not a phase 3 trial. It was a phase 1, phase 2 trial, and it received accelerated approval on the basis of that those results, improved overall survival in a phase 1, phase 2 trial. And accelerated approval means it is like a conditional approval. It's not a full approval. The purpose of giving accelerated approval is faster access to the patients. So, of course, cancer patients can't wait for drugs forever. So accelerated approval, I'm a big fan of accelerated approval. It's a very nice social compromise in which the FDA gives faster approval so that the patients can have the drug sooner. But there is a condition, there is a mandate for the industry to conduct a post-approval confirmatory trial using real endpoint, overall survival or quality of life. And based on the results of that confirmatory trial, they can either revoke the previous accelerated approval or they can turn the accelerated approval into a full approval. So the confirmatory trial results were published, were presented yesterday in the ASCO plenary, and which was a negative trial, as I previously mentioned. So unfortunately, there was no benefit in overall survival in the phase 3 trial. Now, there are a couple of lessons that we need to learn from this. A, we should always be careful about interpreting phase 1, phase 2 results. There was more than 1 year of benefit in the pre-approval trial. That's why it got accelerated approval. That 1 year of benefit is gone. When we did a randomized phase 3 trial, actually there was no benefit at all. And today we are in the world where we are celebrating response rates, progression-free survival from phase 1, phase 2. This trial shows that even overall survival from phase 1, phase 2 is not predictive of overall survival in phase 3. So this is a very important cautionary tale, A. And B, the discussant of this trial made a very strong point that we have already spent more than $1 billion on this particular drug because it was approved as an accelerated approval, and we saw overall survival benefit, and every sarcoma patient wanted to use the drug. All the guidelines said you have to use the drug. So all the sarcoma doctors were using the drug, and it is not a cheap drug. It is a very expensive drug, and it comes with its own list of side effects. And now we see that actually the drug was not helping at all. So now we are in the process of withdrawing the drug. Now most of the countries are trying to revoke the approval. But between these 2-3 years, we have already used this drug for so many patients, and we have spent more than $1 billion on this drug that was not helping anybody at all. So the other important lesson to take away from this trial is, actually, I want to commend the trialist. I really appreciate the trialist who did this trial, because they did it in such a timely fashion. It's not easy to run a big trial of sarcoma. It's not a very common cancer like breast cancer, lung cancer.
Yeah.
But they did it, and they gave us the results within 3 years. Now, I have recently published a paper on accelerated approval of cancer drugs in JAMA Internal Medicine. It came out a week ago. And even in that paper, we saw that most of the drugs that have received accelerated approval, actually, the confirmatory trial is not completed in time. There are so many trials that are delayed, and there are a lot of trials that take more than 5 years. Now imagine if this particular trial of olaratumab, if it had taken 10 years for completion, if they had published the results after 10 years or after 5 years, then we'd be talking about tens of billions of dollars.
Yeah.
Now we're talking about $1 billion that we spent. But now, if it had taken longer, then it would be more and more money spent and exposing more and more patients to a drug that was not helping them. So that's why, at the heart of accelerated approval, we have two points. One is that there will be a confirmatory trial. The confirmatory trial will be completed in time, and the confirmatory trial will use a real endpoint. All things happened with olaratumab. That's why I'm very happy with the researchers presenting this in a timely fashion. That's how accelerated approval should function, and that's why I say I'm a fan of accelerated approval.
Yeah.
That's how it is supposed to happen. You do you get accelerated approval based on preliminary data, and then you run a confirmatory trial. In the confirmatory trial, you use the real endpoint of overall survival, and if the overall survival does not improve in the confirmatory trial, you quickly withdraw the drug. That's what happens that's what happened with olaratumab, so that's how it should function. And the other point of the compromise of accelerated approval is, why do we give accelerated approval in the first place? Because we want cancer patients to have the drug quickly without waiting for the real endpoint results. But if these drugs cost so high, then that whole social compromise is lost. So if the drug cost is so prohibitive that patients cannot afford the drug, then what's the point in having early approval to the drug?
Yeah.
So we have actually highlighted these issues in our last year Nature Review Clinical Oncology paper called The Social Compromise of Accelerated Approval. So olaratumab gives a very poignant example of how that social compromise can be distorted, and actually how the accelerated approval process is supposed to function. So this was a very important lesson. So this plenary presentation was not only a presentation of olaratumab's efficacy in sarcoma, and I think that's not why it got into plenary, but it is also a lesson on how cancer policy affects the trial decisions and how that ultimately affects patients. And it also shows how accelerated approval pathway is a nice compromise between speed and the demand for efficacy. But the main point remains that for the accelerated approval pathway to function well, we have to mandate that the confirmatory trial should be running at the time of accelerated approval. That's what happened with olaratumab. Otherwise, we would not have gotten these results within just 3 years. It would have taken longer. But when the olaratumab got accelerated approval, its phase 3 was already underway. So we should mandate for all accelerated approvals that the phase 3 should already be underway at the time of approval, so that this duration of uncertainty is limited and we can come to reliably certain evidence at a quicker time. It is very common for cancer drugs to receive accelerated approval from the US FDA. It's not as common for the drug to be withdrawn later.
Yeah.
So the other example of a drug that was withdrawn is bevacizumab in breast cancer, which happened many years ago. So olaratumab is a recent example. Now, if we talk about accelerated approval, there are so many issues that I can talk about it, and I have pointed all of those issues in my recent JAMA Internal Medicine paper. In most of the cases, what happens is, even in the confirmatory trial, they don't use the overall survival endpoint. They use the same surrogate endpoint. And so even after the confirmatory trial is over, we don't know whether survival is improved or not. Or sometimes the survival is not improved, but still the drug goes and gets full approval. So that's why I'm saying that olaratumab is the perfect example of how accelerated approval pathway should function.
Yeah.
Because in most other cases, The confirmatory trial does not use overall survival endpoint. And even if the confirmatory trial shows that the results are negative, sometimes it receives full approval anyway.
And just moving on to the Mona Lisa 7 trial, that's received quite a lot of attention at this year's meeting. Do you have any comments or thoughts on it?
Yeah, I do. In fact, we are talking about overall survival, and ribociclib in Mona Lisa 7 trial, it improved overall survival in premenopausal women with hormone-positive, HER2-negative breast cancer. This is a CDK4/6 inhibitor drug, and we have other CDK4/6 inhibitor drugs as well in breast cancer. We have palbociclib, we have abemaciclib. In breast cancer especially, whenever we talk about the efficacy of a cancer drug, everybody assumes that we can never achieve overall survival improvement. So we should be happy with progression-free survival. That's what everybody thinks. Palbociclib and abemaciclib, they have already been approved based on PFS, progression-free survival. And whenever someone brought a point that it does not have OS data, then everybody would say, you should not be expecting OS in breast cancer. This is hormone-positive breast cancer. There can never be OS improvement. But now, in Mona Lisa 7, we see that actually OS is improved. So if you have a really good drug, then OS improves. And I'm surprised that now when ribociclib improved OS in Mona Lisa 7, everybody is saying this is a wonderful drug. See, now we have survival advantage. It actually improves survival. So my question is, if that's true, then shall we go back and look at everolimus, for example, which improved PFS but did not improve OS in breast cancer? And the other drugs that have improved PFS and not improved OS, then are we ready to say that these were really bad approvals?
Yeah.
And should we rethink about them? Because we saw that ribociclib improved overall survival. So what is our explanation for the other drugs not improving overall survival? And at that time, when these drugs don't improve overall survival, we say that we can never improve overall survival, so we should be happy with PFS.
Yeah.
And now we have a drug that actually improves OS. And how can we reconcile these two different logics? So yeah, I'm happy that ribociclib improved overall survival. And that's a great news for breast cancer patients.
Yeah.
But my point is, can we be consistent? And can we say that, yes, OS is the benchmark to improve for our breast cancer patients? Our breast cancer patients really need to live longer if we are exposing them with such an expensive and toxic drug. They deserve that, don't they? They deserve to live longer.
Yeah, definitely.
And we are also approving so many other drugs that don't do that, that don't improve overall survival. So Mona Lisa 7 is a great trial in the sense that it shows that even in 2019, because people say that in 2019 you have 10 drugs, 20 drugs, and even after progression, the patient will receive all of the drugs, so there will be no overall survival gain. Mona Lisa 7 proves that wrong. So if you have a really good drug, you can improve overall survival. We have seen that time and again in breast cancer. Pertuzumab improved overall survival, TDM1 improved overall survival, but for some reason, we always want to be happy with progression-free survival without knowing that the patient is living longer, living better life. We don't know this data, but we still want to celebrate PFS alone. Speaking of which, I want to talk about the POLO trial.
Yeah.
BRCA germline mutation, pancreatic cancer patients. Again, this is a drug. In the POLO trial, we saw that this drug improves PFS, does not improve OS. Now we are talking about pancreatic cancer. Pancreatic cancer, metastatic pancreatic cancer, is a lethal cancer. So for lethal cancers like metastatic pancreatic cancer or gallbladder cancer or small cell lung cancer, PFS can never be the primary endpoint.
Yeah.
Because these people have a median survival of less than a year. So what's the point in improving the duration until which your tumor does not grow by more than 30% or more than 20%? So what's the point in doing that?
Yeah.
So I have a patient with pancreatic cancer. Will it matter to him that his tumor size was 3 centimeter for 5 months, or his tumor size was 3 centimeter for 8 months, but he died at 11 months anyway?
Yeah.
So if he's going to die at 11 months anyway, will it matter to him what the centimeter size of his tumor was while he lived?
Yeah.
It won't matter to him unless if the tumor was big enough and it was causing him symptoms that deteriorated his quality of life. That's why I keep saying that overall survival and quality of life should be the primary endpoint of all trials, but specifically for trials, for disease, for cancers where the survival is so low. Because someone can argue that for cancers where the median survival is 5 years, how can we wait for 5 years to get overall survival data? But in this case, these are cancers, very lethal cancers with median survival of a year or low, or less than a year. So there is no argument about speed of trial completion using surrogate endpoints. When this Apollo trial results were announced or presented yesterday, a lot of us were just happy. And I know the reason for that happiness because A, it is pancreatic cancer, which is a lethal cancer, and we're happy that we have now a new drug for such a lethal cancer.
Yeah.
So having a new drug. So that's a great news. And we were also happy because this was a targeted therapy for a particular mutation, BRCA mutation targeted therapy. And we thought, wow, so targeted therapy works in pancreatic cancer, which is for the first time. Like we never had any targeted therapy in pancreatic cancer. But I look at the data and I don't feel as happy as other colleagues have been. Because yeah, I get those points. I get the point that pancreatic cancer is lethal. We never had a drug. We never had a targeted drug. But does that mean we are ready to accept any drug then?
Yeah.
Yeah, we don't have a targeted drug for 10 years. We never had a new drug approval for 15 years. Does that mean that we can approve any drug now? No. Because if we look at the overall survival curves or overall survival data from this trial, the overall survival, they're on parallel. They're on parallel. There is absolutely no change in overall survival. And actually, they did a very good thing. The researchers did a good thing because they collected quality of life data as well.
Yeah.
And quality of life also did not improve. There is no improvement in quality of life. There is no improvement in overall survival. We want to assume that progression-free survival predicts quality of life, but it did not. Quality of life was not improved. And it's a little surprising trial design too, in the sense that for metastatic pancreatic cancer patients, we are never comfortable keeping them off chemotherapy. Because, as I said, it's a lethal cancer, so we want to give them chemotherapy as long as possible. But in this trial, the patients received chemotherapy for a duration of 16 weeks, at least 16 weeks, and then they were randomized. If they had a response, they were randomized to receiving olaratumab or placebo. Now, I can't understand how can we put patients on a placebo arm.
Yeah.
Because in real world, I think we would never put anybody on nothing, on placebos. Yeah. We would want to continue chemo until the patient tolerates the chemo or until the disease progresses or until the patient dies. So that's a very, that trial design surprised me very much, A. And B, this is a trial of a maintenance therapy of olaratumab versus placebo. So this means for one group of patients, you are not giving anything at all. For pancreatic cancer patients, usually if they were not in trial, they would have received chemotherapy.
Yeah.
So you are not giving anything at all for this group of patients. And for the other group of patients, you are giving olaratumab. And still, there is no change in OS, and there is no change in quality of life. So if one group of patients does not get anything and the other group of patients get a drug, you would obviously expect the progression-free survival to be long. Because these patients are not getting anything. It may not be that olaratumab is working well. It may be that these patients are not getting anything.
Yeah.
And of course, I have heard anecdotes of one patient having a response of 2 years, the other patient having a response of 3 years, but we should not fall into those traps. That's why we think case reports are not good quality studies. That's why we do trials. So we should not fall into the, we can have anecdotes for anything. We can have anecdotes of any drug can have one or two very nice response in any cancer type. But we do randomized control trials because we don't want to fall into those traps. But I think, I have written this in a Nature Reviews paper, I think in 2016 or 2017, I forgot. But if we are doing a trial of maintenance therapy, then for maintenance therapy, PFS can never be an adequate endpoint.
Yeah.
And for pancreatic cancer, PFS can never be an adequate endpoint. And for pancreatic cancer, placebo arm can never be a control arm. And for pancreatic cancer, despite all these issues, if still OS is not improved, and there is no change in quality of life, but there is increase in toxicities with the use of the drug. So what exactly did our patients get, or what exactly will our patients get by receiving this drug? So if we are honest, and if this drug gets approved, which I think it will because the bar is so low these days, then we have to be honest with our patient, and we have to tell them that you take this drug, you are not going to live longer, you are not going to feel better, but yes, take this drug, which costs you $15,000 a month.
So in your opinion, how would you, for the placebo arm, how would you sort of redesign that or make it a bit better?
Okay, if I were designing the trial, I would not have kept the placebo control arm. I would have asked for at least 6 months of chemotherapy at first. And after 6 months, of course, we can randomize to olaratumab versus continuing chemotherapy. And use overall survival as the primary endpoint. And of course, measure quality of life. So after 6 months of chemo, randomized to olaratumab versus active control arm, not placebo, and measure OS and quality of life.
And moving on to prostate cancer, the Titan and Enzimate trials, what are your thoughts about them?
First I have to say that I'm very, this is my disclosure of interest. I'm very good friends with the trial group of the Enzimate trial. Professor Ian Davis, Professor Martin Stockler, they are very good friends of mine. So I always have a soft corner for Enzimate. A, and B, I like Enzimate trial because this is an academia-sponsored trial. And this reflects such a nice, huge collaboration effort across the continents, primarily led by Australia and New Zealand. But Dana-Farber was also participating in it, and Ireland was participating in it. And now I have to mention that I'm working in Canada. Canadian Clinical Trial Group was also a big part of the Enzimate trial. So, A, congratulations on pulling off such a big trial in prostate cancer as an academia-led trial, which is not an easy thing to do. And B, yes, we saw that the use of enzalutamide improved overall survival in metastatic castration-sensitive, hormone-sensitive prostate cancer. So, we have already seen a couple of other trials where we have seen positive outcomes in hormone-sensitive prostate cancer, specifically the use of docetaxel upfront also led to improved overall survival. The use of abiraterone also led to improved overall survival. And as the Titan trial showed, the use of apalutamide also improved overall survival. So now we have plenty of options. But if I have to compare between apalutamide and enzalutamide trial, the Titan and the Enzimate trials, of course, Titan was an industry-sponsored trial. And I guess that's why there was not much flexibility with trial design, because when the docetaxel trial was published, when it was presented, and we knew that using docetaxel upfront improves overall survival, then it becomes unethical to continue patients, to not give docetaxel to patients. Because the Charted trial and later on Stampede trial, this showed that we should use docetaxel upfront, and that will improve OS. So once we know that, for the control arm patients, if we don't give docetaxel, then they are getting substandard treatment by getting enrolled onto the trial. They would have received better treatment if they were not a part of the trial. So that becomes an ethical issue with the trial. But unfortunately, in the Titan trial, the control arm patients were not getting this. But in the ENZAMET trial, when the trial started a little earlier than when the docetaxel results were published, but when it was published, they changed the trial design midway, and they allowed patients to receive docetaxel. So that's why I'm happy with the trial design of the ENZAMET. And the other difference was the control arm in the ENZAMET trial, it is an active control arm, but the control arm in the apalutamide trial, it's a placebo control arm. So I would favor enzalutamide results to the results of apalutamide because of these two things. The control arm is an active control arm, and the patients were allowed to receive docetaxel after the docetaxel results were published. Having said that, if we look at the subgroup analysis, then patients who were getting docetaxel, they did not derive any benefit from enzalutamide, but patients who were not getting docetaxel, they had a substantial survival benefit from getting enzalutamide. So I guess we have 4 options now: docetaxel, abiraterone, apalutamide, and enzalutamide for the same disease setting. And the choice of which drug to use will depend on the physician and the patient, of course. But for the reasons I mentioned, I will not be very enthusiastic about apalutamide.
Yeah.
And the other factors that will come into consideration is docetaxel is an IV chemo, whereas enzalutamide, abiraterone, they are oral drugs. So that might come into factor, but we have to balance that against the treatment duration. For docetaxel, it's a limited duration. You get 6 cycles of chemo, but with the oral drugs, you receive them for 3 years or until the disease progresses. So it's the patient's choice whether the patient wants to get IV chemo for a limited duration and then be happy with it and get over it. So no more chemo, no more drugs for me, or no, I hate IV. I would rather take pills for 3 years.
Yeah.
So and the side effect profiles are of course different. Docetaxel is a classic cytotoxic chemo. It has all the side effects of a classic cytotoxic chemo, and neutropenia, hair loss, neuropathy, all of those things. But enzalutamide, for example, it gives more fatigue. There is a slightly increased risk of seizure. So we have to balance those side effects and cost.
Yeah.
Docetaxel is the cheapest of all the options, and so I think having many options is a good thing, and we have to, and the patient and the physician, they have to reach to a shared decision making. But at least I don't want to see any more trial in the same setting using a placebo control arm.
Yeah. And there was also another presentation presented by Dr. Joseph Tabarano, the Keynote 062 trial. Do you have any other thoughts on that one?
I do, in fact, because this is a trial of pembrolizumab in advanced gastric cancer.
Yeah.
And now again, we come back to the concept of accelerated approval. Pembrolizumab has already received accelerated approval for this indication, and this is supposed to be a confirmatory trial. This trial shows that pembrolizumab was non-inferior to chemo. It was not superior, and pembro plus chemo was also not superior, so pembro plus chemo is out of the question. Pembro was non-inferior to chemo. So I have 2 big concerns here.
Yeah.
A, why was a non-inferiority design acceptable? And I saw that the non-inferiority margin was considered to be a 1.2 upper limit of 95% confidence interval of hazard ratio. So that means we were ready to accept up to a 20% increase in the risk of mortality as non-inferior. We have never asked our patients up to what percent increase in mortality is acceptable to you. How do we know that up to 20% increase in mortality is acceptable? And if we tell our patients that here is a drug, we are going to test if it increases your risk of mortality by less than 20% or more than 20%, then why would anyone want to get such a drug?
Yeah.
Because this is not testing whether it reduces your risk of mortality or not. This is testing whether it increases your risk of mortality by a certain margin, 20% margin or not. any patient would want to get such a drug if there were any other benefit from the drug. For example, currently you are getting chemo, but if you get this drug will cost you much less than what chemo cost.
Yeah.
Okay, then if it is costing me 50% less, then okay, 20% increased risk of mortality, I may accept that negotiation. But no, pembrolizumab cost quite a lot compared to chemo. It's not a cheaper drug. Pembrolizumab is also an IV drug. It's not an oral drug. So I can understand that chemotherapy may be a little more toxic and people assume immunotherapy to be less toxic, although immunotherapy has its own list of side effects, which does not look like a cytotoxic chemo drug side effects, but their side effect is still important and dangerous nonetheless. They can lead to hypophysitis, which can kill patients. So yeah, the side effects are different and they are not as visible as the chemo side effects, but still immunotherapy is, nobody considers it to be a totally safe drug.
Yeah.
So I can't understand the trial design of non-inferiority. We are not trying to improve survival in gastric cancer. We are trying to see if this is not worse than 20% increased risk. So how is that okay for our gastric cancer patients? Our gastric cancer patients want to live longer. They don't want to live shorter than the non-inferiority margin of 1.2 hazard ratio. And the trial concluded non-inferiority. The trial concluded that the hazard ratio, I don't remember exactly, but it was 0.9 or something.
Yeah.
And the upper bound of the confidence interval was 1.18. If it had been 1.21, it would be considered inferior.
Yeah.
It was 1.18, and now we are saying it is non-inferior. So that is one of my concerns about the design itself. And the other concern is, this was supposed to be a confirmatory trial for the accelerated approval that it has already received. So how can a confirmatory trial be a non-inferiority design trial? I have recently published a paper in JAMA Oncology, a viewpoint about non-inferiority trials in oncology. And in fact, we propose that all non-inferiority trials should receive conditional approvals, accelerated approvals. They should never receive full approvals. But here, this is a non-inferiority design trial done as a part of confirmatory trial of the previous accelerated approval it has already received. So the actual definition of accelerated approval, if you see the mandate for confirmatory trial, then what it says is accelerated approval are based on surrogate measures that are reasonably likely to predict clinical benefit. And confirmatory trials will be conducted to duly confirm that there is actual clinical benefit. So how can a non-inferiority trial be a confirmatory trial? Because it cannot confirm clinical benefit. It can only say that the drug is not worse than the drug we already have by a certain margin. This can never be a confirmation of benefit. This can only be a confirmation of the drug not being worse. It's not a benefit. How is it a benefit? And B, I'm worried because I read about this trial in media and from many colleagues, and many people have said that pembrolizumab was comparable to chemotherapy. No, it is not comparable. You cannot use the word comparable to describe non-inferiority. To say comparable, you have to use an equivalence trial, which is a totally different category of trial. This was not an equivalence trial. This was a non-inferiority trial. So what we proved was pembrolizumab is non-inferior. We did not prove pembrolizumab was comparable. We did not prove pembrolizumab was equal. No, we cannot say that. That is simply, that's statistics 101. So I think it is important in ASCO meetings to also have some session on biostatistics and how to, because you would assume that the top people, the very best of the best, who are describing the trials would know that non-inferior does not mean comparable. But everyone is saying that this is comparable.
So thank you so much for offering your thoughts and for participating today. And hopefully we'll see you next year.
Thank you very much.